Welcome to Ortho Insider, the podcast that goes behind the scenes of orthopedics in Canada and worldwide. Today we have a very special guest. This is Dr. Marcia Clark. She is an arthroplasty surgeon at the University of Calgary, and she is the current president of the Royal College of Physicians and Surgeons of Canada. She previously has worked leading surgeons in the Alberta Health Services, and she works tirelessly to improve wellness, equity, and health systems innovation. Welcome, Dr. Clark. Thank you for being here.
Thank you. Lovely to be here.
So our first question always is, how did you get started in orthopedics?
Well, like most orthopedic residents, I had a personal injury. I was an athlete and had a major knee injury that required major surgery and a journey back to athletics. And so that's what was sort of the event that led me to thinking about orthopedics. And then once I went through university and I was exploring, and medicine was the pathway, it was that career that really interested me versus physiatry. But it was also something that people told me maybe I'd want to consider not doing orthopedics because that's where guys go. It was just not encouraged in the same way.
Interesting.
And so my competitive nature came out. And when you tell someone not to do something, some people will lean into it, which I did.
Totally.
I did. Yeah.
It's interesting that you said you were significantly dissuaded. We've had some people say that they've had great mentors to help them, regardless of gender. Did you have any of those people that you really leaned on?
It was the resident group in orthopedics that I really leaned on, that encouraged me when I was a medical student. And so I did medical school at the University in Calgary, and there was a resident group there, including Dr. Veronica Wadey, who's now at Sunnybrook. So she was a part of that core group and getting involved in some research with Dr. Nick Motati.
Yeah.
And then when I was at University of Alberta, because I didn't match into orthopedics, right? We talked about that in a different podcast.
Yeah.
I actually did match. And so I was able to transition into orthopedics. But as I was in my transitioning phase, Dr. Sukdeep Delai, our current president, and Dr. Angie Scharfenberger, who is the head of the specialty committee for orthopedics now in the Royal College, they were the residents at the U of A in orthopedics that I aligned myself with.
Amazing. Tell us a little bit about that process of, going unmatched and then subsequently going into orthopedics.
Yeah. So match day, I believe it still is for residents, is very stressful. And there's this hidden curriculum around what things you need for interviews and to get matched and all that sort of stuff.
Yeah.
I had a very good interview experience, interviewed across the country, but the match did not match up. And because I had committed to orthopedics at that time, to 13 programs, and I was convinced that was my pathway, I was one of the ones that went unmatched. Now, through any hardships, you got to know the highs and lows, but through any hardships, there are silver linings.
Totally.
Right? And so I went through the second match. I matched into obstetrics and gynecology at the University of Alberta. But the silver lining was there was this great program called Surgical Foundations. Back then it was Principles of Surgery.
Yeah.
We're all surgical residents, and O&G is a surgical specialty. Are aligned in a communal program to learn the surgical principles. And so that allowed me still to receive the basic surgical training and then maneuver into transferring into the program. And I gave it a try. I gave it a try, but it was not a hell yeah for me. I was not as passionate as I thought I could be.
Totally. Yes. And was that a difficult process to transition back into orthopedics?
From what I remember, no. I remember having to talk to my program director in obstetrics and gynecology, having to work with the PGME group, having to talk to the program director in orthopedics, and there to be a common understanding. But, it was a process type thing, but I was welcomed into orthopedics.
Amazing. And obviously flourished. That's awesome.
We all remember our program directors too. So shout out to Dr. John McIver. Yeah.
We do.
Yeah.
Shout out to Dr. Joel Warrior.
Yeah. We do. They're so instrumental in our careers.
They absolutely are. Yeah.
Mm-hmm.
And since then, you've taken several leadership roles within provincial leadership roles and now nationally for the Royal College, but also within the Canadian Orthopaedic Association.
Yeah.
Tell us, how did you get into that part of medicine and orthopedics?
So as a medical student, actually, is when I started leadership with the Students' Union.
Cool.
So the Students' Union had a rep from medicine, and I put my name forward to represent medicine at the Students' Union Matters. That's where I met my husband. So he worked for the Students' Union in the governance team, funnily enough. But that was my start in terms of representing my fellow med students.
Yeah.
In residency, I did not have leadership type jobs that way. But then when I became a staff person, I became a program director, and that was my gateway.
Yeah.
I also got a degree in higher education and medical education, so that helped to understand the science and processes of medical education, which led me into SIM, which we can talk about later. But being a program director was the gateway into leadership for me at a PGME level.
And how did that translate now into these like provincial and national roles that you hold?
So leadership roles, there are opportunities that come your way in hospital administration and national specialty societies, in the Royal College or other areas where the groups are looking for content or content expertise. So if you have context expertise in this environment and you feel you can contribute to that organization in a positive way, there are processes for applying. Yeah. And that's what you do. You apply.
Awesome.
Right? And then they have processes for choosing.
Yes.
Right?
Yes, right. Yeah.
So I think there are times when people will say, this opportunity is coming up, would you consider applying? You listen to that. And for me, if it's hell yeah, right? If I'm passionate about the topic, it aligns with who I am and the things I feel I can contribute to, I will apply.
Yeah, absolutely.
There's lots I haven't been awarded or been in positions for, but you learn from all that.
Absolutely. And I think what you're saying about being super passionate, have that whole body yes is so important, because so many times, especially earlier in a career, we're like voluntold to do stuff. Yeah. And you're like, oh, why am I even doing this right now?
As staff, as faculty in any organization, be it in hospital or community, you'll be asked to do things. Yeah. And you do need to know yourself first and foremost, right?
Totally.
Know yourself from physical perspective, mental perspective, spiritual, emotional, etc. Yeah. And know why you want to do something and how you can contribute. Yeah. Right. Yeah. And where your voice is. Yeah. It's okay to say no too.
Absolutely. Yeah. Do you have any tips on how to find your purpose and your voice, especially when you're earlier in your career where everything is just a flurry?
It's a flurry and it's all exciting, right? Or and overwhelming, right? It's okay for your first few years of practice to get settled in, like to figure out. You're figuring out what call is like as a staff person. You're figuring out hospital admin. You're figuring out billing. You're figuring out, risk and CMPA type stuff, right? Because you do not want to get into trouble and you want to deliver best care. You're figuring out how to maneuver through the hospital and the patient environment and satisfy so many people.
Totally.
It is okay to figure out your clinical mojo up front. Yeah. Then I started doing leadership type courses. And I believe every hospital administration does offer this to their clinical faculty, where you can do professional development. And there are courses on knowing who you are, right? Through the LEADS framework, which is a healthcare framework. And the first part in LEADS is knowing yourself, right? And there's pathways through those curriculums. Webinars, pathways, Coursera, there's online MOOCs that have ways of knowing your values, knowing your personality styles. There's several things, and developing yourself as a person and knowing yourself and curating that. Because I think it adapts too over time.
Totally, absolutely. And everyone's, especially what I found being, I guess not that early anymore, but having just passed that flurry, it does change a little bit what your kind of priorities and values are, I think, right?
Right.
Yeah.
Yeah. So, I mean, I no longer have textbooks in the back of my car, but at a time when textbooks were still more prominent than ebooks,
Yeah.
you would, your locker would still be full of the textbooks and the surgical approaches and the master's techniques and fractures and master's techniques and arthroplasty and all these books that are in my office. I don't open any. There's other curated content and availability, but I mean, there was times I never always made sure when I was on call I had my exposures book.
Yes,
right?
totally. One of your passions is diversity and equity. Can you talk a little bit about that, especially being obviously a woman in orthopedics?
So I have to thank Dr. Lori Heemstra and my youngest son for bringing awareness to this. I will disclose that my youngest son, when he was 9 years old, we were sitting watching a TV show. And this scene happened in the TV show, and he sat up and he says, "That's sexism." And I couldn't see it. And I asked him what he meant, and he clearly defined it. And I thought, am I living in this world and not recognizing some of these things that my 9-year-old is seeing?
Yeah.
And so I started moving through the world, having a different lens and doing some reading, and then recognizing that as a woman in orthopedics, where we are a minority, we're only 13% of orthopedic surgeons in Canada, 6% across the world, of orthopedic surgeons are women, contributing to great outcomes in patient care.
Yeah.
And what is that? What is it about the specialty or the system that we're moving and working in that may not attract the great talent of women? Okay? And so working with Dr. Heemstra on the studies about the barriers for women in orthopedic surgery, surveying all of our great members and residents across the country. Thank you for doing that. Applying validated framework, doing a qualitative analysis around that, emerged themes for these barriers.
Yeah.
And from that stemmed then action plans, right? Roadmaps for our leaders, looking at system type change, looking how we support are women and women identifying surgeons in a system that does tend to have patriarchal or colonial structure around it for that system type change, as at an individual type change and the system level type change.
What do you mean by colonial style structure?
Yeah. Well, I mean, we can just look at how agendas are set up. And meeting minutes and governance structures, those are taken from colonial or British type structures, where Indigenous ways of knowing and being, they gather, they share. There's not structure around that. That's an example of a colonial type structure. And hierarchy, right? This hierarchy, right? There's a chair of the department, there's deputy chairs, there's sub-chairs, there's committees. Like those are embedded in governance structures that lend themselves from a colonial type world.
Interesting. Yeah. And is it just that it doesn't quite fit with kind of modern eras? Or?
No. I think it's embedded in everything that we do. But and when you take a step back and you realize that and wonder, if I really want to change a problem, then why am I trying to do it in the system that created the problem?
Yeah, and it's because that really calls out to your other interest, which is health systems change or innovation. Is that right?
Yeah, so those are two different things. Okay, so we can talk about innovation in a second, but health system change. Well, let's use wellness for an example.
Sure.
Because we've talked about physician burnout, health professions burnout. And the corollary on that is wellness or well-being. Wellness is a structure. Well-being is a state of presence, we'll say. And thinking about wellness or well-being from an individual perspective versus thinking about wellness or well-being from a systems perspective. And when we look at the crisis that our healthcare professionals, and we can talk about physicians, are in right now, what are the structures in place that are contributing to our being unwell? And as a individual, which taxpayers paid a lot of money to train me and to train you, and if I'm in an environment that is not helping me perform at my best potential with best patient outcomes, how are those structures hindering me?
Yeah, interesting.
So it is an occupational hazard, and we need to think about system level change.
Wow.
This idea about well-being being threatened and an occupational hazard is not my idea. I have to credit Dr. Melanie Lewis, who's the chair of the Canada Health Workforce Wellbeing Plan, who's helped allow me to rethink wellness and the rebranding of wellness, because it's a return on investment, and we are a resource, and we need to retain our physicians and recognize them.
Yeah.
So this workforce wellbeing plan is led by the Royal College and other key partners. It's healthcare professionals. It received a $3.5 million grant from Health Canada.
Awesome.
So innovation in itself, we'll get to the definition of innovation, or my definition. Quick action. But key to that is it has, I think there's 6 or 9 key focus points. They have an action plan which they're going to deliver on to, and they have healthcare providers on this.
Amazing.
Okay. So, because it's not just a physician problem, it's a healthcare provider problem.
Yep.
So physios and nurses and occupational therapists. And the chairs of all these working groups are actually health leaders.
Amazing.
So that's where the occupational hazard term came from, and the return on investment. Because government, who's investing in us and investing in our health systems, whichever government you want to talk about, needs to understand that their citizens that are delivering care have harm.
Wow, that's wild. I never thought about it that way. That's really cool. So can you give us a little bit of a preview or insight as to what some of these health system changes might be?
So the focuses are on retention and well-being. Certainly the environments that they're working from, the administrative burden, and these are similar things that we're hearing from the Canadian Medical Association and who are at the table as well. The infusion of technology into our practices to potentially alleviate the cognitive burden or the administrative burden that we have. Really looking at our environment as well from a safety lens, right?
Interesting.
Like we just heard on CBC News today about an emergency physician who has a lawsuit out against the BC government around the work environment. Physicians who are speaking up in an advocacy role about the work environment that they are in, and how do they do that in a way that the public can see, but also that they are not putting themselves out.
Well, you kind of mentioned it, but on one hand, we're responsible to the organizations, and on the other hand, we're responsible to the individual provider. Like, where do you draw that balance?
Right. And so as I was listening to the CBC report about this physician who stepped out to speak out, and reflecting on my own role as deputy head of surgery for our Calgary zone, which has over 400 surgeons. As a surgeon, I am a independent contractor to the hospital system, and I have to abide by a series of bylaws. Okay, and if you read your bylaws and what you signed your name to on your professional contract, there are terms in there about speaking out. Right, and how you should speak out.
Right,
and there are structures in place for you to talk to your chair and to talk to the chief medical officers and things like that. But stepping out to talk publicly without the hospital, the due diligence of the hospital is different, and it may actually set you up for professional conduct issues.
Interesting.
Which in itself is canceling.
Mm-hmm.
And as an individual surgeon, ethically, that's really hard to understand and maneuver through.
Very difficult.
Especially when we're in an environment that is stressful.
Yeah.
You might not feel safe. Right?
Yeah.
Big topics.
Is that part of what you mean by the changes in health systems?
Yes. Yeah.
Interesting.
Yeah.
Can you talk a little bit about then the innovation part of it?
Sure. So innovation, and it's a really hard word to define. And so innovation to me might mean something different to you, mean something different to our other surgical colleagues who are walking through the hallways here. But for me, it is, what are those single things you're going to do today that will make things better for tomorrow? That's how I approach innovation. Cool. So how do we take the current CanMeds framework and adapt it after 10 years of life to it to meet the health needs of our public and our patients to be better tomorrow?
Right.
That's an innovation,
Right.
right? How do I take this robotic-assisted total knee robot and apply it to my patients to make them better tomorrow?
Yeah.
So that's my definition of innovation.
Cool.
And so I've only really been involved I guess I've been involved in innovation in different ways. If I talk about curriculum and programs and evaluation and things and moving the needle forward in medical education. But the fun thing I got to do that I'm passionate about is the Creative Destruction Lab.
Yes. Yeah.
So the Creative Destruction Lab at the University of Calgary, and there's one here at UBC, I was a scientist on that, where they needed a medical professional who was touching problems to work with startups and innovators who had medical devices that created something. And I was brought in as a content expert to say, yeah, this is a real problem we're trying to solve, and help guide them and mentor them. And these incubators, the lab itself would it's a mentorship-based approach to help these Canadian innovators and entrepreneurs with their medical devices or there's several other subsets to help them grow and to do something massive. That is their tagline.
Awesome. That's a great
Create
tagline.
something massive, yeah. So they have a whole arm on space. They have a whole arm on ag tech, a whole arm on AI. I was in the medical or the health side, and even health is medical devices versus genetics and genomics, right? So it's a really neat space to be in.
Yeah.
But it's a flip for me because I'm thinking of it from a scientific approach and a fairly critical lens that way. And they're thinking about it. Is this a problem? How big a problem is it? Is it scalable?
Interesting.
And scalable is how many hundreds of $1 million scalable?
Right.
Not, this applies to 5,000 people in Alberta kind of thing, right?
Yeah.
And so scaling, and the principles around business and capitalism, right?
Yeah.
Just, it was a growth experience.
Yeah. Did that experience and having to change that mindset help you with your current role as president of Royal College of Physician Surgeons?
That's a great question. So what it gave me was a lexicon. Okay. Just like that we have a lexicon in orthopedics.
Yes.
I have a lexicon in arthroplasty, a language that we speak. I have a lexicon or a language in medical education. There's a leadership lexicon. Well, there's a business and innovation and type of lexicon. Yeah. And so it gave me the opportunity to learn that a little bit, ask questions. And, it's always helpful to understand how other groups think, right? Because that comes to systems change back again.
Sorry, yeah.
Because when you're working collaboratively across systems and trying to bring people together to make something happen, you need to know their pain points, okay, their mindset, right?
Totally.
Their lexicon, and how they move through this world. You need to know how they're funded, right? Who they report to.
Yes.
Before you can actually start negotiating and moving things forward.
Like all the drivers, essentially. Yeah. So now you have all these skills, and now you're the president of Royal College of Physicians and Surgeons of Canada. Can you tell everybody what they do?
Yeah. Great question, because I get asked all the time. First of all, I get asked, how busy are you?
Yes.
Is it fun? Okay. Right. And what do you actually do?
Yeah.
Okay. Right. So I have a full and blessed life, and I'm managing my busyness, and I'm still clinically relevant. Okay, so that's that question out of the way.
Yeah.
Is it fun? Hell yeah.
Nice, awesome.
Okay.
Yeah.
And what the Royal College president gets to do. So on paper, I am the chairperson of the board. The board or your council helps enable the CEO and the Royal College team to enact the strategic mission. Again, colonial structures. But it's how the organization moves forward. The organization is a membership organization, much like the COA, and it's 57,000 members. Okay, this includes resident affiliates, etc. So the strategic plan, the mission and vision, and all the enabling things below it are how we are going to enhance learning for specialist physicians to better public health, basically. So my job as the chair of the board is to run the board meetings and make sure the CEO has everything that they need to be successful and to be that conduit between them. That is at a governance level. The president, though, is also a very forward-facing public member, right? Interacting with people, communicating about what the Royal College is, the core business, and how we're advancing.
Yeah.
And the CEO is responsible for the operations and keeping the lights on and managing the money side of things very well. So when we come to the core business of the Royal College, standards, accreditation, and exams, and then lifelong learning and med-ed research.
Right.
Okay. Do you want me to break all those down for you?
Yeah, that'd be awesome.
Okay. So if we talk about the core business of standards, there is no country in the world that has a continuous experience of knowing the postgraduate medical education of especially physicians from Newfoundland to Vancouver to say that that education that you got at UBC and I got at U of C and Deb Bartley got it in London, and I'm dating myself here, but and that, you know, I'm sorry if I can't remember residents' names, Dr. Jennifer Layton got at AFC, or whoever's at Dalhousie. We can say with great confidence and certainty that our educations and the product of our educations is consistent training across the board.
Yes.
I know when you graduate from UBC, that if I accept you as a colleague in our practice, I know what I'm getting, right? And that is because we work closely with universities,
cool,
right, and the hospitals, because they have to training has to happen in hospitals to say you meet this benchmark.
Awesome.
So it's a benchmarking opportunity. The frameworks of which those benchmark is CanMeds, and the delivery of it is CBD. The enactment.
Cool.
So CanMeds is a conceptual framework that was patient created.
Oh,
yeah.
I don't think I knew that.
Yeah. So the CanMeds was created in the late 1990s from an initiative in Ontario, where a group of patients were brought together, by the Ontario Medical Association, I believe. Sorry, Dr. Frank, if I got this wrong. It's on our history on our website. And they said, what do you want in a specialist physician? Of all the qualities you want, what do you want? Well, medical expert was there, but they also wanted the other 6 CanMed roles, right? Yeah. And that's how it evolved. Wow. And then it became pedagogically sound, meaning it was grounded in an evidence-informed way in medical education research and scholarship and standards. And then what we do in terms of programmatic assessment is we make sure we set those standards, but they're revised every 10 years because we as society change. Yeah. And so when you think about CanMeds from 2005, or 2015, which was the last one, what has happened in the past 10 years, right? From a societal perspective. Medicine certainly advanced, right? Yeah. But now we have other things that are facing our practice. The way I practiced medicine in 2015 is very different from the way I'm practicing now. Totally. And I anticipate in 10 years' time as well. Yeah. So these frameworks of training are evolving and are reflective in our universities and across the country. But also as a health practitioner now, I reflect on these frameworks in my CBD continuum. Does that make sense?
Absolutely. Yeah, that's a very clear description of it.
The exam process is essential. Yeah. Okay, it's a certification. Yeah. It's my certification, your certification. Yeah. The university doesn't own that certification, just like my license is mine. Yeah. But it's an attestation of that training. Yeah. At a very high level.
Royal College members oftentimes ask, and even locally, I guess within orthopedics, why do we even need an examination, when we have an EPA system that we should theoretically be testing ourselves along the way?
Exactly. So I will answer that in 2 ways. So yes, the ivory tower of EPAs and pedagogically sound curriculum and running educational programs, whenever we create and have an ivory tower or something, the implementation or operationalization of that, we may not get it right away. Okay, so that's sort of number one with EPAs and that CBD translation. Plus, there's this burden of assessment, a new burden that was essential. If we use an athlete analogy, you're not going to run an athlete through a soccer training camp without feedback that's continuous and improving, right? And ongoing. End of training exam is essential at this point, not only because the EPAs and the competencies attained that are attested to by your local facility, they do need to meet the national benchmark.
Fair enough.
But there is this failure to fail. within the system.
Yes.
And that's always existed.
Yes.
So that high stakes examination is an attestation of your ability to meet all the requirements.
Mm-hmm.
We also need a high stakes evaluation for your license. It is something that the government and the public want to say that we have attained this level of standard, this benchmark, just like an engineer has to have it and an airline pilot has to have it.
Right.
Right. And any other trades, people have to have a certificate and a assessment level.
Mm-hmm.
But if you want to go anywhere else in the world, you're going to need that as well.
Interesting.
Yeah.
Fair enough. Yeah.
Right. So that is one of the Royal College's core businesses: standards, accreditation of the 18 medical schools and universities where the learning is occurring currently. Yep. Okay. And that goes hand in hand with undergraduate medical education. We're partners in that.
Yep.
Okay. Examinations or assessment.
Mm-hmm.
Okay. And then I will say all of this good work about the Royal College that does have a heavy focus on our residents and our future members cannot happen without the contributors or the volunteers, the program directors, the committee members, the committee members, the assessors, the surveyors, exam contributors, etc. There are over 4,000 members who contribute to the health of this organization.
Yeah.
And I just want to thank them.
Yeah.
Because we cannot exist without them and do this good work that is internationally recognized.
Yeah. Amazing. So if there's anybody who wants to find out more about the Royal College or your work at the COA, how can they, where would they look?
Couple places. So our website is continuously being adapted, but if you just look up on the royalcollege.ca and look up under advocacy or membership, there's a landing page there on how do I get involved or there's more. Okay. You can always email me, president@royalcollege.ca. You can always call the Royal College. You can email them. Our teams are very responsive. Yeah. That's one thing I've heard, that if a member has a question, the teams are on it.
Well, thank you for opening the doors essentially to the Royal College for us. And thanks for representing us so well. And now as the president of the Royal College of Physicians and Surgeons of Canada. Thanks again for chatting.
Merci beaucoup.